So just right off the top, so we're all on the same page, the reason we're concerned about all of that is obviously there are some risks associated with difficulty swallowing. The big one we talk about all the time is aspiration. So aspiration is when something goes down the wrong pipe. So we all know what that feels like. You take too big of a swallow or something just gets away from you. It goes down the wrong pipe and you hack and cough and carry on. When that happens, when something goes down the wrong pipe, it's going into the airway and can settle down into the lungs. And so if your cough is not strong enough to get everything back out, then you run the risk of having food or liquid get down into the lungs. That can then lead to pneumonia. So aspiration is a big health risk, a safety risk to the patient. That's our first priority. But with swallowing issues, we also have the risk of dehydration because people are not drinking well. Maybe they don't like their thickened liquids. Weight loss, poor wound healing, just kind of decline in general health and strength because of those things. So there are some things we do to address that. The first one would be diet changes, and I'll kind of go through all of these, but we might make changes to the equipment that somebody's using that might slow them down or make them take smaller bites. We might suggest that the person has supervision or cueing when they eat, or that the staff actually feed them to control the safety and the speed and the size of what, the bites that they're taking. So our goal is always that the person is on the least restrictive diet. So making as few changes to the texture and the thickness of the food as possible so that they're safe when they swallow. I've had a couple questions lately about which liquids are thicker than others, so just so we're all clear, thin liquids, obviously, we don't adjust the thickness. It's what you and I would normally drink, water, tea, coffee, all that stuff. If we have to step it up to a little bit thicker than that, then that's what's nectar consistency. So nectar thick liquid would be the next step up. If we have to go thicker, that's honey thick. We have maybe one resident that I can think of right now that's on spoon thick or pudding thick liquids, which is actually thick enough that you have to scoop it off the spoon. It doesn't, you can tip the cup upside down and it doesn't pour out, like your Blizzard at DQ, So solids kind of follow the same hierarchy. We would start with regular solid food where we're not adjusting the texture or anything. Mechanical soft would be one step more conservative or safer. And really the main difference with regular and mechanical soft is that the meat is ground on a mechanical soft diet, and they avoid things like raw fruits and vegetables that are tough to chew and tough to break down. So garden salads are out on mechanical soft, whole apples, stuff like that, those are all out. And then puree would follow that. If they need to modify more, then we go to a puree diet. So when you're passing out meal trays, it's important that you're always checking the ticket for all that information. So it should have the person's diet, puree or mechanical, it should have their liquid consistency, any equipment that they're supposed to have. And that can change throughout the day. That gets updated throughout the day. If I make changes or nursing has to make changes to something, those tickets change throughout the day. So even if you passed the breakfast tray and they were on mechanical, you might pass the lunch tray and now they're on puree. So please just be aware, it's, dietary serves the plate, but then the nursing staff might go in and serve that plate. It's everybody's responsibility to double check that that person's getting the right thing.
And if you're questioning something, go with your gut and don't serve it until you double check, okay? Because, it can, one meal served at the wrong texture can be detrimental.
Right. So, any questions about diet upgrades, downgrades, changes like that? We also use equipment to allow people to feed themselves as best they can. We want to maximize their independence, so if there's something they can use to feed themselves and not depend on the staff, we want to let them do that. We have things like plate guards that sit around the edge of the plate. We have different cups and utensils. Same thing, if you're checking the ticket, you're bringing the tray in, and you're missing a utensil, what do you do? If somebody's supposed to have a curved fork, and it's not on their tray.
Anybody can tell. We want
Chime
you to
in.
interact.
What do you
here.
do?
What would you do?
Call from downstairs, and ask.
Yeah, so you can call, check back in the kitchen, call down to dietary, say, hey, we're missing this fork, just to make it up with the dishes. If somebody has a plate guard on their plate, it's like a C-shaped plastic ring that fits around the outside of the plate. So if you think about how you eat, if you're right-handed or, use your dominant hand, kind of come at the side of the plate and scoop sort of toward the side and toward you. Make sure that when you're setting that person up for their meal, you're taking that into account. So if they're right-handed, you want the opening of the plate to be on the right side so that they can scoop in that way. It doesn't really do them any good if they have to come up over a barrier to get into the plate. Same thing with even just handles of the cup, the way the spout is oriented on their coffee mug, like just kind of take all that in because we want to set them up to be successful as much as possible. Like we said, if something's not on the tray that you need, call down to dietary. If you feel like somebody could benefit from a certain piece of equipment because they're dumping all the food off the side of the plate or they can't quite hold on to their cup that keeps slipping out of their hands, please let us know. You can ask Stacy, you can ask me, anybody from therapy, just pass it on, let your supervisor know.
They'll put a screen in for us.
So positioning for eating, this is one that we come across a lot, we really try to reinforce. Out of bed, upright in a chair is the best position for everybody to be in for eating. If you think about how it would feel for you personally to lay back in your bed at a 45-degree angle with your tray in front of you, that's hard to eat that way. You can't really see what's there, you can't really reach what's there, and you're automatically at risk for aspiration because you're now in this position where the food can just fall right back into your airway. So these people who have weakness and if they're already on an altered diet, you know that there's some swallowing issues there. There are very few reasons why somebody should be in bed eating. So if they are adamantly refusing, I'm not getting out of this bed for nothing, if they're too sick, or if you're feeling like they're not safe in the chair that is available to them in their room, you need to let your supervisor know. Otherwise, they should be up out of bed for their meals.
And minimally, get extra pillows behind them to get them up as, far as possible. It's about safety at that point.
And some people are difficult with their positioning. You sit them up and they go right back down, and there's not a whole lot you can do. But as best you can, we want them upright. Tray and everything within reach. If you have to spin the table around to get it closer to them, do all of that. Think about what you would need to be successful eating. And our last little point is oral care. So when we talk about aspiration of a little bit of water in the end is not that big of a deal. If you're aspirating food or other liquids, that becomes a little bit more complicated. When you have a mouthful of bacteria and gunk that hasn't been cleaned in who knows how long, and then you aspirate, you take all that stuff down to your lungs with it. So then that sets somebody up for a pretty rapid development of pneumonia. So oral care is a huge risk factor for aspiration pneumonia. We brush our teeth twice a day, some people more. Our residents should be getting oral care twice a day as well for that reason. Again, I know people are difficult, sometimes they don't cooperate, they don't let you, I know that. But that is the goal, that twice a day oral care. So when you get them up in the morning, it's part of your morning routine and it's part of their evening routine when they're getting ready for bed. If somebody has dentures, what do you guys do for oral care? What do you do in their mouth? Anything?
At night, you're getting them ready for bed, you're gonna take their dentures out, put them in something to soak, right? Do you clean their mouths? And if not, should we be?
Yes.
Answer should be yes, we
They
should.
usually use mouthwash
Yeah.
in the morning
Okay.
before they put their teeth in.
Yeah.
Because their mouth is dry.
Yeah,
Do you put it on like a tooth ad or a?
Mhm.
yeah, so you
That
can,
or their toothbrush, they usually
Yeah.
brush their tongues and stuff.
yeah. Yeah, so you can take a tooth out, dip it in some mouthwash and swab around in there. If they're capable, they can rinse and spit. If they're not capable with that, to do that, I would stick with the tooth ed and just kind of squeeze as much liquid out as you can. But you want to give that you wake up in the morning, your mouth feels yucky, you want to clean all that out for them. Their teeth should be cleaned, soaked overnight, cleaned however you guys do that. Put their teeth in, and then same thing at the end of the day. The teeth come out and get cleaned, and the mouth gets swabbed and rinsed, and you're good to go. There have been times where people will say, oh, I got this person up for breakfast in the morning, and they still had a green bean in their cheek from dinner last night. That should not happen. If we were doing oral care every night, that wouldn't happen. I think that's it. Just one sort of side note, when you are passing a tray to somebody who's on an altered diet, it looks different. Sometimes the food's hard to recognize. They turn their nose up at it. The last thing they need is for you to say, oh, that looks disgusting,
It might.
It might look disgusting. It might. Some people say, oh, that looks like what my dog eats, but if that's all that this person is allowed to eat safely, then we want to make them feel like that's, it's still good and it's nutritious and it's, so if they're complaining about it, please be mindful of what you say when you're lifting the tray and serving those kinds of things. You can say things like,
Oh,
oh,
doesn't this
smells
chicken smell good?
Yeah. And if you can, please identify the food for them. Like, oh, here's your chicken and here's your green beans and here's your mashed potatoes, so that they know what they're eating. What they say, we eat with our eyes first. So if they know what they're eating, they know what to expect from the taste, that can all contribute to better intake.
Just to kind of tag on to that. You're in the dining room or in somebody's room and you hear somebody coughing, you see somebody spilling their peas all over the table. What do? I don't care what department you're working, if you're dietary or nursing, what do? Clean it up. Yep, you would clean it up. What else will we do?
Get another serving of?
Well, if they're attempting to eat, so, or maybe offer to help them, okay? Let's say we're in the dining room and we hear somebody coughing, like they took a drink and they're coughing. Other than making sure that they're okay, Erin, what would you do?
Make sure they're okay, they have anything, check their mouth to see if there's anything lodged in their throat or their cheeks.
And you're gonna go and write a speech screen, aren't you?
Yeah, if they're coughing on the liquids or the foods.
Yeah, that's what I was getting at, but yeah, absolutely, you wanna make sure that they're able to clear it. And, sometimes it is just a one-time thing. I choked at lunchtime today, no joke. I was laughing and then I'd just taken a drink and I blocked my own airway and probably aspirated. But the point is it could just be a one-time thing like it was for me, or it could be a problem. So we would rather get 6 screens a day and have Margaret check it out and say it's okay, must have just been a fluke, okay? But if one of those people needs a downgrade, you guys are, we all are in this together, so we're a team. So, if you're noticing something, you need to let a supervisor know so they can either call us and say, can you come up and check so-and-so, or put a screen in if we're not here so we can address it the next morning right away, okay? Because you guys are our eyes and ears. We can't see everybody all the time. So we need to know, we want your input. So with that being said, who can downgrade somebody's diet? That happens, you go over and you're thinking, wow, something's different. This patient is not the same. I don't think she's handling these liquids well. So Margaret's not here. What do? Nursing can make a downgrade and put a screen in, and then Margaret, because we just want the people to be safe in the meanwhile, okay? Same thing goes with transfers. If somebody transfers with one assist and you guys go in to do a transfer and the patient is not helping at all, again, let your nursing supervisor know. They can downgrade them until therapy can get in there to address that, okay? We want you guys to be safe. Any questions for Margaret in regards to how do you know how to thicken the liquids? What do we do if nursing downgrades somebody to a thickened liquid? How do you know where do you get the stuff to thicken it? How do you find out how much thickener you put in? Teresa?
It's back in the dining room. Well, we actually have pre-mixed, we have pre-mixed liquids, but it should be in the dining room there, mix this stuff up.
Yeah, so in both dining rooms, in the cabinet, I think it's usually above the microwave, there's a canister of the thickener and there's instructions right on the canister itself. It'll say for 4 ounces of, iced tea or whatever it might be, add this many tablespoons of thickener. And there should be the tablespoons and teaspoons in there. There's a whisk that you can stir it all up with. And you can thicken any drink. Tea, coffee, soda, Gatorade, whatever. So if somebody brings something from home, or they like their sweet tea from the butcher shop and the family brings that in and their nectar thick liquid, you can go and thicken that according to the directions on the canister.
What do you do about food? Do you blend it?
If somebody's on, let's say they're on a puree diet and family brings something in, I would take that to the nurse and say, sometimes the nurse will call the family and say, oh, they can't have this right now, could you bring something different? Maybe bring, a couple packages of pudding or whatever that they could have. But the kitchen can puree something if the family really wants this, this particular food to be given.
If Margaret's the patient and she says, I want to have pizza, and she's on a puree, they can bring pizza in and take it to the kitchen and they'll puree it. Okay.
Any other
Thank you.
questions?
And we're always here, guys. Please don't ever think that there's a stupid question, or if you're not sure about something in regards to, anything that we do in therapy, the doors are always open. Grab somebody in the hallway. You guys can teach us a lot because everybody's good at what you do, and there's things that we're not sure about, we're gonna ask you about. Our doors are open. Grab us in the hallway, let a voicemail. We'll come up and do one-on-one training. If somebody's not sure how to thicken soda and somebody wants to thicken soda, Margaret will come up and show you how to do that, okay? Okay.
Great. Thank you.
Okay, now I'm gonna take a few minutes to talk a little bit about some other therapy-related things. Let's see here, let's talk first about our backs a little bit. Who in here has ever experienced back pain? Yeah, yep. So as you can see around the room, all ages, all different disciplines. I think we've all woken up with a sore back. We're not sure what did it. Does that mean I did something at work yesterday? I'll be honest with you, probably not. If you do something immediately and you feel it in your back, then, probably. But most of the time, back injuries are cumulative. So in other words, we don't have good posture, we're sedentary, we spend more time sitting on our phones, on our computers, we're very active inside of work and outside of work, and we don't always use the best body mechanics, etc. And so a lot of times when somebody experiences an acute onset of back pain, we can't pinpoint exactly what it was that caused that. It's just cumulative, probably muscular, sometimes, vertebral, bony changes, arthritis, that type of thing. But, we all experience it. So what we need to do is be as protective as we can of our backs because we only get one. And as time goes on and you experience those back issues, if you don't make any changes in the way you do things, that back pain is going to get progressively worse over time, okay? So it's important, no matter what age you are right now or whatever, if you're not always using good body mechanics, it's time to start thinking about that, okay? So 8 out of 10 workers suffer some back injury during their working careers, and most of it is due to poor habits. And probably the other 2 just didn't admit that they've had some back pain or injury. So what can we do? What can we do inside of work and outside of work to prevent back pain? I just talked about a couple of them, but shout out for me. What can we do?
Exercise.
Be physically fit and exercise. Stretch. Stretching is a good one.
Chair that actually fits you.
Yeah, ergonomics. If you have a desk job, having a good chair that actually fits you. For instance, in my car, my lumbar support, because I'm short, hits me up here. So I have to deflate my lumbar support in my car, and when I go on a long trip, I roll up a pillow or a towel or a travel pillow and put it in my lumbar spine for support, because it's made for the average person who is not 5'1", okay? So my lumbar support hits me here and actually pushes me forward. So proper support. What else? What can we do to prevent back injuries?
Proper lifting.
Proper lifting and good body mechanics. Exactly. Use equipment when it's indicated and use it properly. And the other one is a big one, and that is ask for assistance when needed. Whether it's at home lifting a package or here at work helping to transfer residents, ask for help when you need it. Okay. So just to reiterate here, to prevent back injuries, be physically fit, maintain good general health, not smoking, just being good in good health. Stretch and stay flexible, use good body mechanics, use equipment and use it properly, and ask for assistance when needed. So when we're lifting, let's just talk specifically about lifting, whether it's boxes or helping to transfer residents. We want to bend with our knees, so not at the waist, we're not doing this. We want to brace, So we want to tighten our tummy, abdominal muscles to give our core some stability during the move. So we're lifting with our legs.
Jeff Truhan would like to show everyone how to do it appropriately.
Only because I just made a comment, bend at the waist.
Did you
were
really?
saying bend at the knees. I did that purposefully between us, and now of course you need to broadcast. He wants me to demonstrate, but.
Because that's what we do.
Yeah.
He wouldn't have thought twice about throwing me under the bus.
But
That's
I'm
true.
gonna respectfully decline,
That's true.
just sit here now and be quiet.
Be seen, not heard back there, guys. Come on. Okay, so we're lifting with our legs. We want to move in smooth motions. Okay. Pivot your feet instead of twisting. Okay, so you want to turn, pivot your feet instead of doing the twist.
What if you have bad knees and you can't?
No, it's tough. I mean, I mean, without getting into a lot of detail, there's a lot of things. First of all, if it's something that you can avoid lifting, you know, get help or ask somebody else to do it. If I've dropped my papers and I have a bad knee, you know, let's say I have a bad knee because I do on my left, you can do a golfer's lift, which is this. Okay? I mean, that way your back is straight, you know. I mean, there's ways around it. Sometimes there's not, and you just have to kind of suck it up and do it because, okay, my knee's gonna hurt if I squat down, but if I do this, I'm gonna have back pain. You know, so just, I think the big thing is just be aware of it. If you're aware of how you're moving, then you're gonna be protective, okay? When you're lifting something heavy, keep the load close to you. So if it's a box, don't hold it out here. If it's a resident, don't hold them out here. Come in close, okay? Keep the load close to you. This is one that I think is really important, and that is encourage the patient to help. If you're transferring a patient from bed to wheelchair, for instance, take the time to give them instructions. Number one, they get scared when we move them suddenly, right? So always be clear, speak loudly, speak clearly, let them know what you're going to do. But also ask them to help. Okay, we're going to stand up. Can you put your hands on the chair here? Lean forward, scoot your bottom out to the edge of the chair. On the count of 3, you're going to help us stand up. 1, 2, 3, okay? I know we're busy, we're all busy, you know, but if we can allow them to maintain some of their independence and help, it not only helps your back, but it helps them. It helps them if they're doing some of the work every day, they're using their muscles, they're maintaining a little bit of independence. So there's multiple reasons that we want to do it that way. But like I said, it's hard with these masks on. So many of the residents, what'd you say? You know, so talk loud, talk clear, but please tell them what you're gonna do and let them help. It's really important. So we talked a little bit about downgrading diets, etc., but and transfers and ambulation, but also keep in mind if you're in there with nursing and you're working with a resident and you're doing their care and you're noticing that their arm isn't moving, you know, the same as it used to when you're washing them and trying to get them dressed, or you can't get their legs open enough to do peri-care, or you know, they're not transferring as well, or whatever. Those are also good reasons to get therapy notified, okay? You know, they could have something musculoskeletal going on, they might be having shoulder pain, their leg muscles might be tight that aren't allowing, you know, you to get their legs apart enough to change their brief or do the peri-care, and those are all things that we can help with, okay? So please let your supervisor know so we can get involved. We would much rather get involved early. You know, you guys work with these patients day in and day out, and you might be able to notice subtle changes before they get worse. And if therapy can gets involved early, we might be able to do a couple weeks of therapy before things would go too far the other direction, okay? So sometimes I think we wait too long because we think, oh, you know, they're just having a bad day. And then tomorrow, oh, it's just another bad day. And then that becomes that patient's norm. Oh, well, she's always like that. Well, she wasn't 2 weeks ago. And it can happen quick in this population. You know, somebody being sick with an upper respiratory virus or something and being less mobile, laying in bed for 2 weeks can really kick them down in their ability to move about and perform transfers, to help with their ADLs, okay? So those small declines, you know, are really important to let us know about. Okay, when you talk a little bit about falls, what is a fall?
Change of plan.
Change of plane, yep. So a fall is defined as a sudden, unintentional change in position which results in an individual either hitting the ground or floor or another object below the starting point. Like if I were to fall and hit this table, you know. Falls, without getting into a lot of statistics, falls are huge in this population. And we do everything that we can every day to try to prevent them. And I think we do a really good job of that here, but they still happen, right? So every year, 1 in 4 people over the age of 65 will fall. 1 in 4, that's a lot. So if you have, 4 grandparents still living, one of them is probably gonna fall this year. It really is a lot. And in long-term care, 50 to 75% will suffer 1 or more fall. That's a lot, okay? That's a lot. And 20 to 30% of those that fall will suffer moderate to severe injuries, okay? So we need to do everything that we can to prevent the falls. What can we do to prevent our residents from falling? A lot of these things we do every day. What can we do to keep our residents safe from falling?
Beds in low position.
Say that a little louder so everybody can hear you.
Keep the beds in low position.
Bed in low position,
Make
okay?
sure fall mats are on the floor.
Say that again?
Make sure fall mats are on the floor.
Yeah, so whatever we have put in place as preventative measures, make sure that that's in place. Whether it be an alarm or a mat, hipsters, bed in low position, maybe the bed against the wall. We have a lot of tools, but there are people that, we have frequent fallers that have every intervention in place, and sometimes they still fall. It happens. But, we need to make sure that first of all, that everything is care planned. So if you walk into that room and there's no fall mat there, you need to make sure that you let somebody know so that gets taken care of right away. Maybe that had been removed. Maybe at morning meeting we decided that person didn't need that any longer, and it was discharged, we discharged that order. So that happens as well, but it's better to be safe, okay? So, make sure everything is in place that should be in place. If somebody is ambulatory and they use a walker, make sure we keep their walker within reach so that when they get up, that they can safely do that. Let me see here. Oh, I know what we can talk about. What's this?
Gate belt.
What's a gate belt used for?
Transferring, walking,
Who needs one?
everyone.
So, general rule of thumb. Gate belts should be used if the patient requires physical assistance, okay? So if the patient just needs supervision to walk, you don't need the gate belt. If you have to lay hands on them to help them get from the bed to the wheelchair or to walk down the hallway, you should have this on. Why? Why do we use a gate belt? I need something from this corner back here. Why do we use a gate belt?
Make sure they don't fall.
Yeah. If somebody does pass out or lose their balance, you have so much more control, okay? And I'm not saying I've never done it. I'm guilty too. If I'm walking with somebody, I'm gonna grab them by the back of the pants. That is humiliating. We give them wedgies. We tear their pants. It's not right. We shouldn't do it, right? I don't want somebody grabbing my pants and walking me down the hallway. So it's a dignity issue as well. But just a quick story. Years ago, when I was working in a hospital, I had a 350-pound patient that had a hip replacement 2 days earlier. She was doing great, walking with the walker. I walked down the hall with her, and all of a sudden she says, "I don't feel so," and she passed out on me. Out. I had a gate belt on her. I was holding it here, I was about a step behind her. When she said that, I came in real close and she passed out, and I just lowered myself and her to the ground. She was out, and I'm going, help. And we got her up. Her hip was not dislocated. She didn't have as much as a bruise on her, and I was not injured either. So, you know, the belt just, all she had on was a hospital gown. There was nothing to hold on to. So, you know, this gives you that control, okay? If you're doing a stand pivot transfer, you know, you have something to hold on to. You can keep that resident in close to you so you don't hurt your back, okay? So I'm gonna tell you that I'm not over and skilled for 8 hours a day. I'm not up on the floor. But when I do walk through and treat patients over there, I'm not seeing these being used. And it is in the policy here that these be used. So if you work in nursing and you don't have one of these, don't know where to get one, don't know where they're kept, let your supervisor know, because it's for your protection, okay? And the protection of the residents. Okay, any questions? Okay, thank you very much.
Thank you.